Yeah. The Z monster will attack, you see. Hey. So later I'll be sharing a little bit more of the orthodontic component for like adults, how we also do non-extraction for them, and some TMD management. And lastly, I'll finish off with some sleep dentistry as well. Then I think we'll complete today's program. Okay, so class 2 cases. Right. So I think when we manage the bite, we're not looking at just teeth movement. We want the whole jaw to come forward, or whole jaw to move backwards. So if we can really get the tongue up one more time to get this big wide expansion intercanine space, you can think about it as in widening the goalpost, opening up the space so the lower jaw can come forward. So a lot of times you can see the very constricted, narrow jaw with a deep bite. The intercanine space is very tight. So the lower jaw actually got stuck behind the two canines. So if you can round up the two canines, you can translate the whole jaw from a class 2 to a class 1 position. Whole jaw comes forward. Right? Now of course you can do a retraction at the same time. But when we do that, obviously you're going to face some interesting gaps behind, right? But the truth is, this open bite at the back is posterior insufficiency that we discussed earlier. The tongue has been low and the vertical is not sufficient to support the jaw. Think about this. The curve of Spee is actually deepened because of the tongue resting on the posterior teeth all the time. So if you can keep your tongue up to roof and keep the back end touching the soft palate, the base of your tongue, the underside, will not make contact with your lower posterior teeth. Okay? If you don't have the contact at the posterior side, your lower teeth would have made that journey upwards, and the bite would have been more level. And if you try to do treatment for patients without telling them about the tongue, and you try to just get the jaw forward, they constantly keep their tongue on the posterior teeth, you will always face that posterior open bite issue and it will never end. It will never end. And the patient will blame you for not being able to do so. We blame the aligner company for being lousy, you can't move the teeth up, but actually the tongue is still lazy, like a big fat bloke using the back teeth like armrest. Right, it's sitting down, pushing everything down. So when we try to clear this, sometimes we do combination, right? So we do aligners, sometimes I don't put the attachment, then I get my patient to wear trainers on the aligners at the same time. So you want them to chew gently, we'll do 5, 10, 15 minutes. Right, that will help to condition, but at the same time, every time they are doing that, it's like using a mega chewy, like, right, all around, sitting the aligners into the position well to keep a good tracking. So you can combine this so that the whole So because of this, I tend to use less or no attachments, because I use this particular method to tighten up the position of the aligner against the teeth and let the full aligner contact the teeth for movement. So at the same time, you're training muscles, right? So you kill two birds with one stone. Combine not only just the munchies or trainers, you can put the myosport up there so then they can also get a very clear spatial position of the tongue up in the roof and stabilize it, swallow right properly, and then, right, get the whole orbicularis strong, get the tongue strong, right? This is how you condition it. So this is a line, so you've seen this, and just run this through again to get your patient. I say twice a day. Sometimes you can use one, some cases you can use two, usually one. So that is a possibility that we can even use, for example, if the patient chews on one side only, then you can see if they're chewing on one side, this part, the contralateral side, the palate might be a little bit more collapsed as well. Because as your tongue chews over, push the bolus of food over, it actually shapes the jaw too. So if you want to attract them to use the other side, you might be able to use the myosport, stick on the other side of the palate, and try to get the tongue to also move over. Okay, make use of all the natural activity to condition the shape and the size and volume of your oral cavity.
So in cases of deep bite, you are not relying on any milling screw positioning in the program.
Yeah. Later I'm going to show you an adult case.
So you're basically achieving a very vast degree of alveolar growth. That will compensate.
Okay.
Or development.
I think it's not wrong to put the tag and use that for movement as well, right? But I'm just trying to make life quite easy for my patient and for myself, right? It's again like you can use expanders. Expanders expand the big, but expanders occupy the palatal space so that the tongue cannot touch the palate. So the moment after you're finished with the expansion, your tongue must come in to prop and scaffold. If not, the collapse is going to be imminent. So then you have to rush to train the tongue to go back up. It's like such a chore for me after a while. So I decided, okay, let's just do it this way. If I get the tongue up, tongue goes up, tongue stays there forever, right? So what would the effect be? Then you start to realize, okay, it's quite achievable, and you might not give the best outcome within the same frame. Let's say you use more mechanical forces using whatever method. The stronger like for example, if you use a MAPI, right, you can expand more. But if you don't use, the patient is expanding throughout their life, like what Dr. Isoko Kondo is showing. So I'm not rushing anywhere with it. Yeah, so that is how I approach it. But again, if you want it faster, it's no wrong.
We understand we are influencing the growth and development. So would there be an age cutoff?
No age cutoff.
So even in adults we can...
Yes, exactly. So I'm going to show you.
Sure.
Okay, I'm going to show you. So I think, yes, good line of questions, because everybody was like, okay, then what should I do, right, if I want this done? Okay, that's my question too. I use Invisalign all this while, but one thing about them is that I even at my level, I have a chance to influence the team. I went to Costa Rica, I talked to the trainers, with their in the ALTA program, I help out in the clean check, manage whole design and development. I also can't make changes up there because they always will throw back this word, legal. They have a large legal department, no change possible until you clear that. Okay, so too big, mammoth, no chance for me to change. Then came Graphy. Okay. So within the community of Invisalign providers, they talk about a new material that can be used. It can be, okay, so you can search it, Graphy, like as graph, paper graph with a Y. So Graphy is a material that can be used to print aligners, print splint, print other things, right? And they can even print crown and inlays and all, and dentures and all, depending on the material that you choose. So the orthodontist got excited about this because it is special in the way that it has shape memory. Meaning if you put it in hot water, this aligner or a splint will turn out of shape. But you put it back in room temperature in the mouth also, it can come back into shape. Alright? So now they're asking the dentist to think about printing their own aligners. Right? And you'll be able to capture undercuts and more detail. So you put it on, it's very fitting and it can do the job better in that sense. So when I got to know about Graphy, so last year spent quite a few trips to Korea to learn about it. Then we brought it back to Singapore. We registered it, so we're the first one. In a way, we're also the distributor for them in Singapore as well. But I also know that Singapore will have limited space and manpower cost is very high. I can't create a small factory on my own to print. So what can I do? So I sourced up and I found this Singapore company, OneSmart. So they are mainly Australian, incorporated in Singapore, right? But the factory is in Indonesia. All right. Yeah. Making full use of everything that is best, because Singapore has the best tax structure for any company, and then Indonesia has the land and the manpower for you to develop a manufacturing plant. All right. So I talked to them and say, look, if I have Graphy, can you print for me? And they said, definitely, right? They're also looking out for it. So now we are in the process of testing all the equipments so they can print Graphy material for aligners if I subscribe to them or prescribe, should I say.
What are the programs, like you can do your own attachment and everything?
Yeah, so everything is
They have AI programs.
There's no AI program yet. Yeah, so it's just the material. Graphy is in charge of just the material. You can use any program to design, and you can use any machine to print. As long Graphy is just the material.
But OneSmart has a program, or they're just printing.
They have their program. They make their own aligners, and they have an orthodontist behind the scene to do all the programming. And it takes and the difference is they take this whole job off us. So whoever is using Invisalign, right? We have to go back home after we treat the patient and do clean check. Okay, OneSmile has orthodontists who can help you to do that work. So as long as you communicate to them very clearly your treatment plans for all the different kind of malocclusion, they will give you a plan that you can possibly accept. Yeah, and move on. So similar, you also have to check the clean check, but instead of being done by technician, you have orthodontists helping you out. So I talked to them and decide that we want to push forth non-extraction protocols. So that the orthodontist and I came up with the algorithm, right? So that we can add all this in. But I think more interestingly is that the material is standard PU or Graphy, you can choose. Next is, it is all recycled. It's the only company in the world now who is recycling. It's also halal certified because it's based in Indonesia and it went through all the necessary certification processes to get it halal certified. So that's why it is now available in Saudi Arabia as well. Right?
How much is how expensive?
Is 40% reduction in price compared to Invisalign. Yet, you heard about dental monitoring? Yeah, so so this is dental monitoring. Oops, sorry. Okay. Sorry, I can't play it. Yeah. But this is a French app system that we are using for the past, I've been using for the past 5 years for all my aligner cases. So what they do is that they take the video and it is like a photo taking, and from there they create the AI checks so that it is tight or not tight, fitting or not fitting. The AI will pass them, and then if they're not fitting all the time, they will be referred to the dentist for more work, for checks. If they are doing well, the patient is kept away from you, right? So you can do a lot of remote monitoring for the patient and double up, triple up the chair time because of this. So what I've done is, since they have that as a add-on system, as the core system as well. So when I'm using Invisalign, I have to subscribe to dental monitoring, paying almost $200 Sing dollars a year for the usage. Month-on-month, about maybe $13 to $15, all right, to screen every patient. But for OneSmile, it is all incorporated into it because they have a special agreement with them. So now we have this AI system, we have special material, we have algorithm to do non-extraction. Then we need the myofunctional component. So the MyoSpot is the help. So I talked to Dr. Shihab also to add that in. Dr. Nada, she's a speech therapist, so she will come up with the plan to do the myofunctional component for the system. So that when you get the orthodontic case, for example like this, right, you will be able to scan and you will receive exercises as well.
Wow.
Yep. Then Manchi, and then that's the CEO for OneSmile. So what we're going to do is going to put this whole thing and create the OneSmile Linguadontic package, right? So that any dentist who wants, or if you believe in this, you want to do it for the patient non-extraction, right? You can subscribe to the system, right? And then the patient, when they receive the box, everything will be in there to help them to be on the journey. Also helping you to do it, because we also know that it's not easy to find good myofunctional therapists at times, right? But this will be able to complete the whole journey for the dentist and also for the patient. And this will help us to do, okay, so it's so smart now, right? This whole system. You need to submit your first IOS, intraoral scan. They create the model. Every week when the patient does this for checking, it's also creating a new model based on photos or pictures that's taken. Subsequently, if you need to do a refinement because it's not fitting, they will have the shape and model of your teeth. Your patient can be anywhere in your country or anywhere in the world. They can take the STL file and create the model and then do the aligners. So your patient doesn't even need to come back in again for a new IOS scan, because this will replace the subsequent scanning that the patient will need if they need a new set of aligners. Yeah. So it's going to revolutionize how we're going to manage patients orthodontically, how we can manage them remotely, and this is going to definitely improve on your chair time, utilization. So I think that is quite an attractive point. So hopefully the whole thing will come through within the next few months, right? We'll definitely update all of you. Like I say, currently it's available in 4 countries in Asia, right, and in Saudi Arabia as well. Because according to OneSmile, right, they went and the Saudi orthodontists and the royal family, which is also looking into this, they are the orthodontists as well, really like the system. So that's why everything was fast-tracked within 6 months to have it on the ground running, right? So we're looking at definitely expanding to the rest of the different cities and countries. Okay, so but of course I've been using Invisalign for a long time, since 2007. I say I was still very, very comfortable with the system as well. Especially latest, they have the CBCT version. I'll explain in one case later. So this one is early intervention with mixed dentition. Of course, you can wait, but it will be troublesome. You can also bond 4x4, or you can do plates, and you can do many other methods to actually jump the bite. For me, straightforward, get the liners on, right? Then you can get to this point very quickly. So when the dental monitoring, what you see is this. So this set of photos is taken is indicated July 2020, and this set of photos is in May, and of course there are many other photos in between. Okay, and this whole sets are used for analysis. Then the green means it is fully adapted, move on. So a patient will move to the next aligner. Move on to the next aligner after 1 week. Move on. You decide how many weeks, how many days they're going to wear it for. For default 7 days, some maybe even 10 days. Right? If they're doing very well and they want me to speed up, I can also just request for 6 days wear or 5 day wear as well. Alright? So now you see the red box. Alright? The red boxes will indicate that it is not fitted fully. Patient is then asked to stay on for 2 more days or 3 more days based again on your prescription. Mine is 2 days. After 2 days, patient check again, fitted, they can move on. So this way they are kept wearing the aligner until it realizes the position before they move on. Right. So you can see sequential tracking, October 2020, before this July, so October is almost jumping over, and then November, and then you can see all these changes over time. Yeah. So the good thing about this is, especially when it comes to aligners, it's always about compliance, right? And if a child is not wearing, parents sometimes blame us, not them, right? If you have all these records they need to take and they're not doing it, right? You can just show the full record. You know when they're taking exams and you know when they're going for holidays. It's all in there. So it's very helpful. You okay? Okay. So, and even for adults, this is also a very good conversation piece, right? If they are also leaving blanks, right, then no one to be blamed, except themselves. So for arch expansion, again I mentioned earlier, is sometimes the word expanding. So of course this is still a child, right, or growing children, and this is her, this is her. Okay, what I'm trying to show is this: there is a missing premolar, right? So this is the X-ray she gave to me when she came, that there was a tooth still stuck in there. So is there a possibility for me to treat? Okay, 2 options: extract the other side to match, or extract 3 other premolars to match upper and lower, or let's see whether we can open up the space. So over a period of time, you can see, so we started in July, then June, so, and then April. Notice that then with the rounding up of the arch, that premolar now starts to peep out of the space, alveolar space. And then over a period of time, again, another year, is coming into the whole arch. So eventually, we managed to restore, and of course, there's still some movement possible, but generally, we're almost there already. So adult non-extraction, like this case, she's 31, right? If you look at her front 2 teeth, it's actually even more, midline has shifted onto the right side because one of the lateral incisor has been excluded from the arch. So again, what can we do? So if I show you this as the initial plan, I think most dentists would not agree that this is going to happen because she's 31, right? But thankfully, it happened, right? And it happened in 1 year, 3 months, right? So it's not going to be that slow as well. So there's a possibility of this to this, right? And you notice, even when you come to this part here, right? You see the mid-palatal bone, and this is 1 year later. It's not the same. I did not put anything on top. So just from the patient's own work, she's able to distort. And the very fact that we're doing orthodontics, the RAP is happening, right? The whole biology is in a flux, resulting in this ability to actually create possibilities like this. Of course, then my colleagues will ask, oh, are you just tipping the teeth? It's always the case. Orthodontists will ask you, do you tip? Okay, fine, let's see. So I have another case, more recently coming to see me. He's 38 years old. So you can see, yeah. So when the jaw is actually tipping in there, you have to understand this is from the fact that, okay, whenever you, okay, let's try this again. You can put your hand to your face, okay. Then if you swallow, just swallow. Okay, swallow with tongue thrust. Think about it. Okay, swallow with tongue up. Okay, so when you do a tongue thrust, the face will move, right? Yeah. So 2,000 times a day, the vaccinator will activate. So if you breathe through your nose, not moving. If you breathe through your mouth, cheek is moving. Yeah, 11,000 times a day, the vaccinator is activated when you breathe through your mouth. So you can imagine if your mouth breathing, your reverse swallowing, right? All this is going to activate the cheek and then continue to push the whole buccal segment inwards. And if the tongue is low, then you can see this canine drop off, or whatever you call it, the curve of speed, right? Then you can see your upper teeth trying to grow down to catch up because your lower try to passively erupt. It cannot come up because the tongue is always sitting. So the upper teeth want to make contact, but can't make contact, so the upper teeth continue to chase. So that's why you have this. Genetically, it won't translate like this, right? But functionally, because of the adaptation and habits, that's why you see this kind of phenotypes. Okay. So and you can see from here too, you see the whole row of teeth is being pushed back. Remember when I told you that if the mouth is open, the lower lip is bracing against the front teeth here? Yeah, so there's a lot of force inwards that is pushing those teeth every time you swallow, breathe. And sometimes you see a big overjet. There's also the resting spot of the lower tongue, lower lip. Yeah, the lower lip stuck between the two teeth. Then you see that whole overjet area. Okay, so getting to stretch his tongue. Obviously, you can see he tried to lift, but not too well. But okay, he understood. He came for 2 more consults just to be sure that I can do it for him, non-extraction. Right? I say, let's go, and he decided to go. And this him, right? 8 months later, right? 8 months he delivered this result to me. So to me is is a huge change from here to here. I think I have another shot, just a moment. But basically, right, is to really show if your myofunctional component is done correctly, which in this case, right, he changed his habit very completely and quickly. That's all I can say.
To what extent, according to your experience, if we had not included the myofunction, just with the Invisalign?
I also told him give yourself about 2 years, to 1.5 years to 2 years to reach that kind of result. So he did it 8 months. To me, is that it is really fast forwarding the whole process very, very quickly. And yeah, just a moment. So as you can see the comparison, 8 months. Okay, I think this is the key area to look out for. Any aligner system, the buccolingual movement is easy. Yeah, they translate. As long as you wear it, it'll just move. It's the verticalization is going to be very difficult, right? So for this to happen, all I can say is that he lifted his tongue sufficiently so that there's enough head space for the bottom teeth already. And then that whole tongue is now nesting in this area and is helping with the whole rounding up of the upper arch by exerting forces on the inner shelf of the upper palate so that the whole buccal plate is also pushed out together with the whole alveolar process with the root inside. So we're not moving teeth, we're moving the whole dental alveolar process, right? And then when the lip is now in the right place, there's no more inward force. This row of teeth can just into position, right? Easily. And then getting up. So what I can see is, yeah, there's a bit of dehiscence here, right? So before he only gave me his x-rays, and this round I managed to get
thin phenotype as well with precision.
yeah. And in Asian, we are always bestowed with the thinness of gum and thinness of bone, right? But this is after that first round of movement, and you can still see that the teeth are generally in bone, right? Right. So this is what it is after the first round of movement. So this is an area of concern, but the rest no concern at all. And what I did was, just time it, move the teeth in. Whenever they propose the attachment, I just leave it. And mind you, yes, this case was done, all this extrusion without attachments. Yeah.
With
So-
no attachment.
No attachments.
So tongue posture followed by monkeys, 15 minutes 5 times a day, equaling to 1 hour 15 minutes.
Oh, no need 5 times, let's say 15 minutes, twice a day would be good now. Yeah, 1 or twice. I think most people can't get past 2 times. Yeah, if they get 1 time in, I'm really happy already. Yeah.
So we're basically introducing osteogenesis.
In a way, yeah.
So we have to rethink our physiology.
Yes.
We were only told that it's 1 millimeter movement a month.
Yes.
It's much more than that. In a 3-dimensional way.
In a 3-dimensional way, but not only that we talk about how much I can move, but they never talk about how much resistance. So when I was in Korea, when we were talking about this, they're always talking about the measurement of the aligner force. So now they can measure all that aligner forces. Then I asked the question, Prof, okay, we have the tongue with the lips and the cheek. If that is exerting the force, we know they do. What are the forces then? How can we add that into the calculation? Good question. We can't. So it's just like this. Imagine this shirt sleeve is the liner. So we're always calculating how much this force is exerting on my arm now. But I can easily put my tongue here and start pushing too. But they can't calculate that. And they totally disregard that as well. And I think it's not right. Yeah.
So do you do a little bit intrusion on anterior or mainly just posterior extrusion?
Generally extrusion. Okay, because in some cases, yes, agree with you can be because of the deep bite, they're biting into the palatal area. Then for those cases, when you move them forward, you might want to intrude a little to compensate for that over eruption. But his case is actually he's biting on. I'm quite comfortable with the anterior height. So what to me is really the posterior is insufficient. So I want them to be up rather than the front down.
Not very good. That's very hard to extrude.
Yeah.
Posterior.
True. I mean, I call him my teacher as well, right? Yeah. So he showed me it can be done. Again, a lot of times when we have this concept, until it's shown to us, even for myself, I'm not convinced enough, right? Yeah, but it's done in such an elegant way, right, that he just showed to me that 8 months. But we do have a bit of a problem later on at the posterior. He was lazy after this. So the second round, he was a bit lazy, his tongue came back down, and we have a bit of open bite at the back, worse than this. And then we got another round and we caught up again. Yeah. I'll add those slides in came in recently. But I was just saying that it's just the case. The tongue has to be up. And it is like us getting up the escalator that's coming down. We're walking up there. The moment you stop, you're going to go with it. There's no stopping. You have to be active all the time, just like any muscles in the body.
Have you done some study with CBCT for long? we have a case with CBCT.
So since this CBCT for Invisalign is available, yeah, we've been doing a lot more of this with the low dose. Yeah, so it's very helpful. It's actually faster than OPG because the data is actually even less. Yeah, so
Very good comparison.
yeah, so we'll be able to see more, and I'll be presenting those as well. Yeah. So next area is of course the TMD management in using neuromuscular dentistry. So this is again to me a perfect application of the tongue, which just now you already tried. Like, see, if you put the tongue up, your clicking gets less. Okay. So in order for us to measure the bite, we use a neuromuscular method using myotronics. And this way, it's just like a car with suspension alignment issue. You drive it into a workshop, jack the car up, let the wheel hang loose. Right? The system allows for almost 18 different parameters that you want to check. You can check on muscles, you can check on joint sounds, you can check on swallowing pattern, right? The velocity of opening and closing, all those things can be checked. But not to try to complicate my life too much as a general dentist. Also, I think, yeah, a lot of this measurement, especially last time when they're talking about full mouth rehabilitation. When you measure and you switch over to a full mouth, you got to be really accurate. The moment you set everything in ceramics and it's wrong bite, your patient is going to complain to you forever. And you need to redo things, it's expensive and troublesome. Okay? But for me, because I'm working with the body and I have a slightly longer runway, because most of my cases always will start with orthodontics, right? So this gives me a little bit more time to even out the whole situation and see where the body goes. So once we measure, we know the spot, we use transcutaneous electrical neural stimulation, right? And then we can measure up the bite. Interestingly, this device is actually used in Japan in 67 university, right? So it's actually quite well adopted by orthodontists in Japan. But they only measure it for like just taking an X-ray for the sake of knowing, but not act on it. Yeah. So through the coronoid process, you have the fifth and seventh nerve. The seventh nerve or the facial nerve is more superficial. So if you have a TENS machine, turn it on, you see the eyebrow twitching first. Yeah. Then once you go deeper with a bit more power, then you will see the mandible pulsing. So usually we'll put in the pinky to make sure. Yeah, I can feel the lower incisor biting on my finger, and we know that the mandible is activated. If you want to, you can also run to the cervical area and run the shoulder one as well. But to me, it doesn't really need to for me, so I skip that. So we do this measurement so that, like for example, a patient has a bite like this. So if you want to do orthodontics, you say, okay, where is the midline that you want to follow, upper or lower? Okay, let's say you want upper, then you then have to move all the teeth to the right side in order to settle the problem, right? Okay, so now if you go through this process and you determine the bite, then it's a different story. So from here, after we take the bite, this is the bite. Then this bite is the bite that I send to Invisalign or any system. So this will be replicated. And then from there, I do level, align, and vertical jump. Okay? Yep. Okay. So a patient presents to you this way. For us, we want straight teeth, midline to coincide. Then sometimes we think about moving teeth, right? Yeah, we're not checking for the functional shift. If patient, let's again This case is because she's always mouth open and her jaw deviated because the teeth grew and then guided her to. But it is not that her jaw joint doesn't allow her to come back to neutral. And this position, if you put the tongue up, she would, from here, okay, think you remove that bite registration material first, okay? When she, just say her mouth is without any bite registration, when she put her tongue up, you will get this position. That's what I'm trying to say.
So you ask her to put her tongue up and then close.
Nope. Okay. Sorry, one more time. I use this neuromuscular method to measure her, to know her floating position. This position is determined using all this gadgetry and then finally deciding on the position based on the reading that we have on the screen. And that tells me this is the target zone. Then I will take the bite based on that target zone to get to this particular situation here. Right? So once I take the bite, now my approach to orthodontics is not by just moving from here. I start orthodontics from here. Okay. So then it will be a very different way to approach it, and you can notice there will be very few lateral movement, but a lot of buccolingual, tipping, root top, and then later on verticalization. Sometimes it's just a physical jump, but it also can be from extrusion or intrusion. Okay. So this case, 14-year-old, when she came, she's complaining that her left joint is painful and she suffer lock. So the cartilage is stuck. When she was trying to open, it's not allowing her to rotate and translate easily, right? So she has to maneuver, then it can get out of the whole joint and come back in again. So that's why her mom always see her doing that, and when she eats, she has a very funny face or funny action. And so for her case, yeah, so there's a really push forward, a push to the left, and of course the muscle symptoms that can come with it. So from here you can see, if she is allowed to open fully, she can return to center, right? And then she collapses. So to me, there is no restriction, capsular restriction or osteopathic kind of issues, right? In the jaw joint is functional. Okay. So through the method, we measure, and then we settle on this position, and then we can even translate it into a repositioning splint. So when she put on that splint, she can perform a very even opening, closing without having a deviation anymore. So if you look at the pimple, you can understand that this is the same day, with and without, on the day of issue. So the moment we put it on, the whole physiological and functioning part can be translated immediately. Okay? So once they're on this, they will ask me, how long do I have to wear this for? Especially some adult patient, right? I just tell them, during the day, you must train your tongue to do the job. Once your tongue can be able to hold you up, close your mouth and guide, you can do without that splint. Your jaw will not deviate anymore. Okay, another question to ask, like this one.
How long between the two videos?
The movement just now, you see? Same thing.
Yeah.
Same thing.
So you do this in office?
Oh, sorry, 3 weeks. So after we measure, I still have to send the bite to the lab.
Yeah.
Then they can fabricate this device for me. So I call it a jaw joint guard.
Like splint.
It's a splint, but to most patients, a mouth guard is a mouth guard, a splint is a splint, it's a mouth guard as well. But until I explain that this is for your jaw joint, not for your teeth, right? Okay, so when I use this splint, jaw joint guard, I will be measuring that three joints. Neck joint, TMJ left and right. So my patient will be sitting on the Sally chair if they can. So with the Sally chair, they are now straight arms. Yeah. So I level up this part from the side. From my side, I look at her, my nurse will look at her, we look at her at the side, we check, just to get her as neutral as possible. Not like stiff, but as long as neutral, they're not tilting the head. If they do, we'll be just pushing it, yeah, to hold while the bite is hardening. Okay? So once we capture that, then again, like I mentioned earlier, we need them to be able to help themselves. So the guide is only helping them to stabilize and guide them to this position, but they need to be on their own. So how to get the tongue to function. So when the tongue is up, then they won't deviate as much.
Is it always on the bottom?
Sorry.
Yep.
How long did you put that on the spleen before they?
3 months, 6 months, 9 months, 12 months, depending. Most 3 months and below will settle the especially on musculoskeletal, muscle-related issues. 3 months, usually the headaches are off, the neck pain is gone. Yeah, but we talk about tinnitus, we talk about vertigo, right? So sometimes those things will take a little bit longer. But how long they want to be on the guard is another story. So some will find that this during the day, you take it off and they are comfortable, they can just bite and eat still. Nighttime you put it on again for their sleep. If they're comfortable like this, then they stay like this. So 60% of my cases might just stop at this and then done. Yeah, daytime they're rehabilitated. So yes, during this rehabilitation, they go and see my speech therapist for myofunctional training, so that we can get the tongue to do the job again. Then with the splint, they use it until they're comfortable, right? And then daytime they start to wean off. They depend less and less on it during the day. Nighttime, you put it on, sleep with it, no need to bite, just hold it up, just anti-grinding to a certain extent because of the splint design with a ramp. When they bite, they will be discluded at the back, so less biting on the back. And also the volume gives the tongue a bit more space. If you always put your tongue up, like say myofunctionally, now you can sleep better because your tongue will be in the oral cavity. That part I'll touch on the final stage when we talk about sleep dentistry. Yeah.
For the upper, are you doing Invisalign at the same time to get rid of interference if there are any?
No need. I don't worry about it at the moment. Yeah. I wait for it, then I
do it later.
Yeah, together. No rush. No difference. Yeah. So then, of course, after a period of time for this, she's growing and she's guiding her jaw. You notice that she's actually able to open and close. Now, without the splint, just on her own, she's able to tell the passageway, the passage of opening, closing trajectory. Then the last part, then we do the liners, right? And we rehabilitate everything.
Is it always on the bottom?
Pardon?
Is it always on the bottom? The 8-footed?
Yes, because the lower jaw you have the easiest way to correct on the 6-axis. Upper, you stabilize it, then the lower you can actually change by thickening and thinning. So imagine you doing a full mouth rehabilitation using the upper low arch with an over denture. Full mouth rehab, over denture, lower jaw fixed. Also, why I keep the upper arch open, because I want the tongue to rise up, occupy the space as much as possible. So there's some special paper, right, that is mentioning about all this splint therapy for, especially for sleep apnea cases, right? You want to make sure that you don't want to block out too much of the upper arch spaces, because the tongue needs to go up there. And they also advise that you be able to manage TMD, because a lot of the sleep devices induces TMD. Yeah. So for me, thankfully, I came from the of joint management first. So I use this method to do my MAD or split or whatever. I'm safe. I wouldn't dare to say 100%, I'm safe. So while doing her orthodontics, you notice that she is still tongue trussing, right? So she's always doing this lateral tongue truss, and that's why the gap doesn't close. So previously I was trying to use buttons and elastics to actually close the gap. It's to no avail. It doesn't close. Yeah. So but once I correct her bite muscle system, so ask her to learn how to swallow and correct the aberrant swallowing, right? Within 4 weeks, it was much tighter already. Yeah. Then obviously we noticed that hey, she has a tongue tie, and we went ahead and do the tongue. So now that you can see the lift when the tongue is up, definitely much more vertical opening. Of course, now if given an option, I might do this earlier than to do it at the end. Yeah, so you can see all the progression changes. But also interestingly, looking at the jaw joint where we first started out in 2014, you can see that's why she keeps collapsing to her left. So from the pain or discomfort from the collapse, the muscle guarding and pulling keeps her jaw away from the space, right? But this pulling obviously distorted her condylar area, and then and with that, it aggravated because in that space over there, the cartilage is getting even less room to move when you open and close. So a lot of clicking or even lock. But about 2 years down the road, when we rehabilitated the whole opening pathways, you notice that the whole condyle actually remodeled as well.
It's fully seated.
Yeah, it's fully seated down in the middle. So sometimes, so a lot of times when I look at the TMD or the joint pathology, I would not look at, I'm not too worried about the jaw joint. I look at how the teeth, the function. If that part is not settled to provide space for up here, then whatever we do here is, futile. So we need to go down, look at the whole space, get the whole, even the upper arch neck joint corrected first, before I start even talking about the TMJ. If not, again, I think the reference point might be not right. This is the right side, so not much difference. But I think it's still slightly better, right in the middle. Right. So after all that, you can see now she can easily open wide, back to her bite. And that's it. Okay, let's talk about this. How often is the patient in MI?
MCP, you mean?
MCP, MI, CO, CR.
Throughout 24 hours.
In the 24-hour period, how often are they in the
Less than 10 minutes.
Yeah. So the study says that it should be less than 40 minutes. If they are very greedy, maybe they are up to an hour, a lot of snacking. Even when they're eating, the teeth might not come full in contact. The food is in between and they stop. So we hardly is in this position. So why are we so...
Exactly.
Okay? So that means, right, the free floating position is dominant throughout the day, and we can't let the two jaws just float in mid-air and then, so something has to hold. So your lips hold in the anterior region. If your jaw is too left or right with your lip together, you can tell, right? But if your mouth is open, you can't tell that clearly. So your lips will give you a bit of sensory guidance in the anterior. So this also helps you with the anterior AP positioning. So the jaw can come more forward if the lip can stay together, rather than clockwise rotation of the lower jaw and then end up with a higher angle and then longer face, right? And then of course, when we discuss orthodontically, the high angle case, brachyfacial or whatever, it is not, what's the point of saying that? I'm just saying, okay, there's a diagnostic point of view, but we can treat that, we can change. It's not a genetic code that they end up with. Of course, like say 30% is just still genetic. The rest is still moldable. Yep.
So humans are open bite race. open bite race, therefore teeth coming in contact within 24 hours is less than between 6 and 12 minutes.
Yeah.
Because we're open bite race. Open bite race.
Our open bite race.
Race as a creature, we are not meant to be having them together
Yeah.
for a long period.
Yeah. So we just have to have the idea that inside the mouth, okay, outside the mouth, lips is sealed. Inside the mouth, tongue is up. Then you have the gap. That's it. Then your tongue is up sufficiently at the posterior part. Your neck will be aligned, and then your jaw will fall in the right place. If you start from that position, when you open and you return back to that position, the jaw doesn't deviate that much. Then your teeth will then erupt into the right place, in the right plane. So this patient came, Pooja, and she came
and last night I had such a bad time because when we were in the room, so here you guys can have fans, right? And I need air to be coming if I have to sleep comfortably, otherwise I'm really uncomfortable. My heart rate goes up and I'm really uncomfortable. So we had to actually change, like downgrade the room because they had a fan in that room and I could sleep comfortably then. But in lifts and aircraft and any closed rooms, I'm like really uncomfortable because I don't breathe through my nose, I breathe only through my mouth. So
we're going to change that.
Yeah, so patient do come and just say, yeah, I just breathe through the mouth. And that's why she's suffering what she's suffering, right? 3 years of pain, 19 dentists later, still not resolved. One of them say coronectomy, cut off your 2 joints, you'll be fine. Yeah, and of course her parents say no. And she was angry with her parents for saying no. Yeah, almost suicidal. Okay. When you're in pain, I think we can't rationalize. So these are also very good telltale signs that they've been always opening their mouth. I always tell my patient, how do you make salt with seawater? You evaporate the water, leave behind the salt, right? So this is the case. Open your mouth, evaporate the water, saliva, and you leave behind the minerals. And that's why on the front of the teeth, if they keep on having this quick formation of calculus, I know they're still mouth breathing or at least incompetent lip seal. Alright, so we see interference there, and this is all she can do. This bite in her face is the lower jaw deviation, right? And obviously she's not comfortable. Always complaining about facial swelling, so the lymphatic drainage is not ideal as well. Okay, so you can see all that. So now you can capture that low tongue position from the curve of speed. So we do the measurement, right? So this is this position. So after the measurement, this is the position, and then that's the split. And that split, fill in the blanks, right? Okay, do you see that it's coincidental? The midline? Yeah, almost there, right? It's not that I aim to move left, right. I didn't do that. I measure from a different perspective on the neuromuscular rest position and the concentration of dots, like a marksman shooting at a three-dimensional space. Then I can determine the floating position of the patient. Okay. Then once it's done, she wore the splint and she is breathing.
Tell me about just last 2 months. 2 months first. What's the big difference for you?
So I'll tell you, for when we started this orthodontic.
Okay.
So before that, my symptoms were lack of sleep, very disturbed sleep, waking up clenching like anything, swollen face, weight gain, like a lot of weight gain, and pain, of course, a lot of pain in the joints, in the muscles, in the temple, in my neck. So I was like a mess. And I think as soon as I bought this orthodontic, also my swollen problem, which was like, it had become a huge issue for me to eat and
Actually, the solo portion, before we even started with the orthodontic, we were trying to do a lot of functional training. Does it help you during
yeah, Yes, it helped me a lot, especially the tongue. So the tongue exercises are really important. So the tongue exercises help the swallowing, the tongue exercises help the neck, the posture, and overall strengthening. And I think it's helped me a lot. Like the tongue exercises have helped me like crazy. So that's something I would totally recommend. Also concentrating on breathing. So currently, as soon as I put on the orthotic, right? In 2.5 months, I was down by 10.5 kgs. And I saw, of course, I paid a lot of attention to my diet, but I've dieted for the last 5 years to kind of try and lose weight and nothing happened. But in the first month, like every 3 days I would see my weight and it would be like 1 kilo less, 1 kilo less. And I'm like, okay, what's happening? Do I have another disease or what? But I realized that it was because I was breathing better, I was sleeping better, so I was not waking up tired, I had a lot more energy. I still have a little bit of muscle stiffness, but overall I feel a lot better. So I think the orthotic and the myofunctional training is really important, and also losing weight. So these are the things that
Yeah. So basically the yeah, it's quite a lot. So she flew in her parents, and then I asked for some of the recent photos, and she said, "Wow." Okay. All results cannot be repeated for every patient. But yeah, it was okay. The weight gain component is very clear. As long as you're not breathing well, you're going to put on weight, right? Reason is, later I'll discuss it, but we'll talk about it now. Okay, when you breathe, you need oxygen, then you get your ATP through your Krebs cycle, right? Okay, so even when you're sleeping, you need energy. But when you cannot breathe, you have oxygen desaturation. You drop to a certain point, less than 11%. Now your body can't even have enough oxygen to do the transformation to ATP. But you need still more energy, the truth is, to fight for this lack of air. You need to, heart rate must go up, blood pressure must go up, your sugar must be released, clearance and removal of waste, breathe harder, right? Okay, now you have to dig into your reserve. So you take 3 times more through anaerobic respiration to then supplement this lack of oxygen. So you will wake up in the morning with a lot of energy debt. Okay, so when you're having energy debt, the best way is to eat, because you like look for high caloric food. So they even do a research for some shift worker. After you can't get enough oxygen, you don't rest well, right? That's it. You want high energy food. So once you take that, you are energized. But that is not your deficiency. That's not the limiting factor. Limiting factor is still oxygen or air. So you go through the whole cycle again. Blah, blah, blah. Yeah. So at the same time, leptin and ghrelin, your hunger hormones, will be upregulated, so that it will help you to just eat more. Right? So once you can get more air in, right, this whole thing will just let you be more efficient in your metabolism. And that's why she lost 10.5 kg in 2.5 months. We have many cases where after we just issue this splint, do some tongue exercises, we do see huge weight loss. Yeah. So in a sense, we're trying out this whole method where we go bite and then we go into the orthopedic and at the same time myofunctional to stabilize, correct, sometimes pain relief before we move to Invisalign phase 2. But not all cases goes to phase 2, right? Some might be comfortable enough, right? We stay at phase 1. Of course, for her case, we noticed, there's a drop video over here, but it's okay. I think what we noticed is this issue here, where we then correct the patient orthodontically to get to the right one. Okay, let me just power up. Do we have?
You're about that, right? Yes. There.
Just can't fit in. Is it on?
Yes.
Is it on?
Okay. So for her, we know that the this in her original bite was the interference tooth, right? Okay. So if we don't correct that supraerupted 7, her bite is not going to close properly. And by adjusting to this position based on our neuromuscular position or the spleen position that is tested to be alright, she is pain-free after almost 8 months or so on the spleen. Okay, then we will now send this information. Of course, I'll mount this up in my Invisalign case. Then of course, in early cases, we always end up with them emailing me or replying on that, your case is mounted wrongly, right? But to me, I'm just saying, look, I've taken into consideration the jaw basis, everything is right, please proceed. And what they'll do is this,
So
they will,
it was a non-working side interference.
yeah, not only just the non-working side interference, but also to, in the sense that, you know, we check on the car, axle and suspension first. Once I settle the suspension alignment, then I put on the tires. Yeah, so the way the teeth are positioned is really not the most critical. I must know where should be the jaw bases. Then I line the teeth up accordingly.
So did you take the scan like this position, or do you give it the spleen? How do they mount?
So usually, yeah, you just take a scan because now everything is a digital workflow. On their side, they won't receive anything physical from you, right? So you take your
scan with the spleen in place.
yes. So sometimes you even have to modify the spleen a little in order to be able to scan in, because the spleen might cover the teeth and you might not be able to do the buccal correlationship, right? Yeah.
So no occlusal interference correction, irreversible correction with the powers, none of that. You just
Meaning enamelplasty and all this. Yeah, I don't like it. Yeah, because one of my dentist friend tried to do that on me. He did one spot and I was like, oh, yeah. So I decided, I say, look, you wear it down yourself. Yeah, I'm not going to give you a perfect bite. I'm going to give you this range. I'm going to train your tongue, and your tongue will tell you exactly where you need to go. Bye bye. Here you go. Oh.
our teachings in university is starting from the other side of what you have been developing.
Yeah.
And you're starting with
Totally
aligning the chassis versus
Yeah.
not looking straight to correct
Because-
position inclination.
Because they don't have a chance to see the babies, the child, yeah, and see them grow, and then later see them turn old as well. Yeah. So I'm glad I'm just not a specialist. Yeah.
So the vertical dimension is this is a new vertical dimension.
It's a yes and a no, right? Usually this vertical dimension can be excessive. Okay, but do you know that you can open up to 50 mm? or for ladies, you can open up to 40 mm. I have this leeway of 40 mm for you to place you. You'll still be fine. You're comfortable. It's just like this, okay? You don't do your work with your hand extended this way. You don't do your work with your hand close to you. You can do work any distance in this will be just about right. Okay? You have a range. So this vertical, I can even lie it down. I can do a retainer. But after that, you know, if you correct yourself in your habits and your function, you determine what is the vertical.
But you're gonna set the teeth at this vertical dimension.
Pardon?
The inversion line gonna help you to move the teeth to this vertical dimension.
You give them like a range to move to, so they will do their best to close up. So this is before, this is after. Oops, sorry. Yeah. So before, after, before, after. So perfect.
Functional.
Functional, in the range, right? Not that bad, right? Then take it there, go, right? And see where it goes.
When they wear their aligners, they don't tend to go back to that.
Interestingly, yes, it's like sometimes a liner, it is like a discluding split, also. But that's
It's what I'm saying.
disclude the bite. It's a discluded or open about.
The aligners are still the same aligners. You don't have the
nothing
on there.
Yeah, nothing on it.
Before you start the aligners, you leave them in. You said 3, 6, 12 months before you put them in aligners.
Yeah. Again, functional or shall I say, depend on their pain situation. Yeah. If not, they have no pain, then I'm not even going to put any orthotic. No jaw joint gum. I take the bite, I send them right into aligners. Yeah. And sometimes I don't even take the bite because they are alright, close there, then we just go and at least I won't create a situation bring them into a lock-in position. I feel. Yeah.
What that helps you with the orthotic?
Please repeat that again.
What lab helps you with orthotic?
Fabricate. Do
You-
you fabricate
lab.
use
Okay.
it?
So currently there's only one that I can depend on. It's still based in is Las Vegas. Yeah. Red Rock.
That's
You
good.
send it to Vegas for this?
Yeah, I sent it to Vegas for this.
Oh.
Yeah, I checked with my local lab, asked them to carve. They're like, so literally they need to carve the occlusal of the 6, 7, and the premolars, and the whole ridge from canine to canine. Yeah, so then when we bite, it will be just like as though they are teeth. And then when it's back with me, I will carve those as though I am doing enamelplasty, occlusal. I deepen the groove, I create the marginal ridge clearly. I check on the bites. Yeah.
Like you're doing when you're constructing a mouth gum, a sports mouth gum. So many
Great.
Interestingly, it's like this. Okay, so when we get guards, usually the mouth guard is negative print on the surface, so it's depression, right? So the upper teeth bite into the depressed position. But the surface is positive. It's like another biting surface of the teeth. Yeah. So it takes a little bit of that imagination from your technician to first take a bite. So they have the first blank is just again depressed points. So now how do you develop from a depressed point and you have to carve around it to make it into a cast tip?
Occlusal carving.
Yeah. So it has to do a reverse carving in that sense. That's why not all labs can do it. So now we're also of course hoping, still discussing to look at digital now, maybe ExoCAD, maybe other thing can help me to design in such a way that will reproduce this and I can 3D print myself. I'm waiting for that day.
So now that you've achieved the final result, everything is balanced from muscles, lingually and labially. You don't necessarily have to rely on fixed retention. what we call as
Yeah.
essential, gold standard, Royal College of Surgeons guidelines.
Yeah. No fix. Definitely no fix.
Because muscles are in most happily balanced position.
Yeah.
We don't need any fixed retention
Yeah.
per se.
Because what I do is not perfect. The patient can do, and patient can perfect it in due time. What we need to tell patient,
Muscle training, yeah.
and also, is that there's a factor of time in this whole treatment.
True.
Yeah, we need that maturity, the mellowing. It's like making red wine. You need the time to actually make it better if you continue with your system. Yeah. Rather than expect that I can deliver. Can't. I say, look, first thing first, I say, how old are you? Some say, oh, I'm 33. Okay. So you took 33 years to get to this problem and now you're asking me to help. Okay, is it fair that I ask for half the time that you spend screwing it up to tidy it up again? So I want 15 years. Is it okay? So long? Okay. Okay, 7.5 years, 1/4. Okay, half of that. 3 years, 4 years.
Reverse psychology.
Yeah. So if I spend that, I think it's fair that they give me that time. And then you also have to understand, I won't complete the time within the time frame. It's just as best as I can within 3 to 4 years. The rest is yours. Don't screw it up again. That's it.
So no retention basically. No fixed, no removals. That's
Removable, yes, because usually we still ask the patient to go on retention, 6 months minimum. After that, and they say you can decide you want to go longer. You have to have the confidence your muscle function is at tip-top situation. Because if you don't, it's going to run. It's going to
if your orthotic has the indentations for the uppers to stabilize itself, you don't necessarily need anything to.
Of course, if the patient, some patient after the finishing, right, after they get to this, some they just wear retainers, and some might ask me for another orthotic. Yeah, because they find it so helpful when they sleep. Yeah, especially when they sleep at night. It's so much more volume that they can actually sleep much more comfortably. Yeah.
Just a quick question. Do you work with the osteopath or cranial chiro to help you to stabilize it while you're in the ortho?
It's yes and it's yes. Yeah, yeah. So I work with a whole let's say group of different practitioners. Because sometimes I'll explain to my patient that they need more help. They should go and see them. Even sometimes we get them to see them first before coming to see me. But it gets too complicated because yeah, you don't know when is the right time, right? So then what I want to do is I don't want to make it like I must send everybody out to do everything else before they come see me.
They don't follow.
Yeah, I will do what I can first. Okay, do it to my best ability. Then everything else is an add-on, is an add-on, is an add-on.
Sorry, one more question.
Yeah.
So the leeway space is what we understand physiology, 4 millimeters, between 4 and 5. So we have the orthotic all night. The natural space that we normally maintain between the teeth is obliterated because you have introduced splint. So
Good point.
So
basically, what we measured is the right muscle length. Okay? And patients still need to add 4 more mm to that height. So what can they do to increase that height? Lift the tongue. That's right. So they're under all the time. They're actually under. That's why they have this bite. So after I measure, it's correct. So I have this German, so tall. And when I did the measurement, so sometimes I get about a 4 to 5 and 3 to 4 mm because I put the magnet and it's measuring this position. And this gentleman has 10 mm. So of course the lab also will call me in this. Are you sure? But I look at him and say, yeah, this is the deficiency that I think. So his vertical dimension, yeah, is huge in terms of the leg. He has a full deep bite, 110%, I would say. And for his height, he needs that volume. Yeah. So once you put it on,
tongue up basically, in summary, and one thing, It's just leaving the muscles of mastications, buccinator, temporalis, medial pterygoid, lateral pterygoids, in the most comfortably stretched position.
Yeah.
The normal.
Yeah.
head.
So you can also summarize it this way, say that if your cranial nerve number 12 is firing, your 7th nerve and your 5th nerve can rest. Your facial and your trigeminal, right? Everything that's innervated by it can just go into neutral. Thank you. No battery.
Not charging.
That's yeah, charging.
It's on. The light is on.
Okay.
It's charging now.
Okay, this is a quick hack in case you don't want to spend like $30,000 USD on the machine. Okay, sometimes just use a toothpick. Get the sharp tip one. Get the patient to bite in between the teeth, right? With a cheap retractor, you will roughly get. Okay, then you scan this in and send. You can just change it. Especially for the deep bite patient, if you put on a retractor, they can't bite into the bite, right? If they find it very hard, they have to use their face to chew. That's why they feel very tired all around. Yeah, but if you can get them to bite forward, yeah, this is actually, they're right. So for all this patient with a deep bite, it's like you making a denture for them with teeth that is too short, or and they have to use effort to bite. I made that mistake for one old lady, and she came back. I can't chew my vegetables, right? So because with that it's too short, she had to really use a lot of catching force in order to do that. So then you will end up like this with spaces in between. Then you just get Invisalign to or any of the system to then do the just move. Sorry. Just move and move until your bite can close. She's a retreatment case anyway.
Any special instruction to the technician? Or
Initially, yeah. So to let they have to appreciate that your open bite or floating bite is intentional. Yeah. You have to tell them to follow iOS, right? Because they might do something else. So photos and iOS must really show the new bite. Then they will be able to do the necessary.
Did you use the Invisalign when people advance, those 4 tools?
Yeah.
You use them?
I do. Yeah. So it's most cases we do that. But I've been using mandibular. I've been doing mandibular advancement before then.
And you work on your own method, so you don't need that.
When I get them to wear my the trainer with the aligner. So the trainer indexing when the jaw comes forward is already a mandibular advancement. Some patient will actually sleep with the aligners and the trainer in the mouth throughout the night. So they wake up like the aligner is like laminated onto the teeth. Yeah. And they learn to do the mandibular advancement. I mean, through your sleep appliance.
It's advancement.
Yeah, and also you need people to go on the morning after bite to go back to the position, right? Some cases you want to do that because you don't trust that mandibular forward position, which can be a problem. Okay, but people can get stuck in that position too. So you know what I mean. You think about it, then there's a possibility. So for mandibular advancement, if you don't measure it like how I do it, sometimes patient already is off axis. So that means they are not in the correct alignment. And you want to mandibular advance them like this. And then after a while they complain that my joint is having problem. Right? So that's why you need to make sure that you at least set them into neutral and then you can advance. Right? You'll be safe.
do you give any sort of de-equilibration, like dosage or an NTI
Yeah.
splint.
So because I do this measurement externally, I'm asking for the muscle length in a 6-axis positioning, right? Then my splint cover every teeth, right? So I don't, yeah.
Really
Because if you,
start with
okay, any loosey jig or anterior jigs, right, like NTI and all this, right, you don't take in consideration the posterior movement. So your masseter can still contract and you can still close some position. So if
because when I have a pencil between my front teeth,
yeah,
there is zero activity of the
yeah,
zero.
correct.
So
So that one is yeah, because you don't have your posterior contact.
yeah.
Yeah. So for me is that the splint, when it's in the right position, even if you fire, I'm fine. Because your teeth is in axial direction, the force is through axial direction, there's no damage that I need to worry about. Everything is in neutral, you use the force. But when you are in excursive or lateral movement, you are still in contact, that's the problem. Yeah, either you like talking about working side or non-working side interference, yeah, or group function. Because when they are in that position, then your teeth is off axis and now you're loading them. You can split them, you can crack them, you can cause dehiscence, all these things, and your joints is also suffering. I don't want that. Okay? Then you say you use the anterior and then you disclude. But for me, when I use the splint, it's the same thing. Okay? It's full contact in axial, but it has a ramp in the front. When you go into excursive, the posterior teeth is not touching. Yeah, because we ramp it up to the canine ramp. So this is also our protection during sleep.
So you're happy to leave the occlusion in group function at the end of the treatment, which is where it ends up mostly. Or your lateral excursion photographs.
Okay, good question. Okay, that will lead on to the next point, sleep bruxism. Okay, if person is grinding that in their sleep, then group function is going to kill them or kill their teeth. But what if I can get the person not to grind anymore? Yeah. Okay. So how can we not grind? So my point is just that at least you know that you don't have to do a million things to get all these things sorted out. Just one thing right. Get your tongue up, close your mouth, breathe through your nose. Okay, 4 things. Swallow correctly. You'll be much better off. Okay, so for sleep issue, there's actually a lot more at it. So we talked about it. There's mouth breathing, primary snoring, upper airway, and so last time, right, they're all known as sleep-related breathing disorder. So last time we are just okay, I won't say last time. Now we are still measuring OSA with AHI. Okay, because it's the only thing that you can really measure, right? That means you stop breathing or you still continue to breathe. That's it. Yeah. But what does it really tell us? Not enough. So that's why now we have more on this measurement. We check on RDI, right? So yeah. So we for the RDI, we're looking at the respiratory disturbance index, right? So how many times you get disturbed, your RERAS, your effort, right? And primary snoring is ODI. ODI also cover all this actually. ODI is oxygen desaturation index. So how much your oxygen drop during sleep? Yeah, is also key. If you're obstructed, you drop just 2%. No one is going to complain. 3%, no one wants to complain because the US insurance decided that 3% is easy to hit. Because last time we dropped by 3%, they will fund your sleep device. So they changed the rule to 4%. So you have to desaturate by 4% before you can claim. Okay? So how well you are dead or alive is not determined by your health authority, but sometimes it's another force at work. Okay, so RDI, ODI, AHI, all this now come together to give a better picture of whether the person is breathing or not during the night. Okay, So sleep-related breathing disorder, we realize one of the biggest challenge is at the throat or oropharynx area. So if that one is blocked, you will end up not being able to breathe. And why is that place blocked? It's because your mouth is open, your tongue is down, and you close it up. If you can keep your mouth closed, your tongue up, you will be like that. Remember that baby? Yeah, his mouth closed. He can sleep supine and he still can breathe because lips sealed, tongue suction, hold it up, airway is still open, no disturbance to his airflow. And this is how our ancient fathers, mothers are like that too. But we change. So another way of looking at this, for the longest time we always talk about positional devices, right, therapy, so I say, you do your surgery, you do your appliances. It's all trying to settle the anatomical position or problem. But now you can see there's a lot more to it. There's myofunctional, right? There is loop gain or breathing pattern, and then also arousal threshold, very much related to all this ability to breathe or not. So we talk about just this whole point here, Sleep Medicine Journal 2020. You notice that last time for almost 100 years, should I say, right? If any child starts snoring, the pediatrician will send them to the ENT. The ENT look at them and say, look, you have two big adenoids and tonsils, let's remove them. That's it, right? Cut. Yeah. But now you can see that 60% of the children experience residual OSA. Divergent in outcome, meaning good and bad, short term, good, bad, short term. AT did not provide any significant long-term benefit. So all that cutting goes to waste. Waste of everybody's money, put the patient at risk, and come down to nothing. What are those adenoid and tonsils? They are just defense system. They are the Vidya belt. They're there because your mouth breathing, you're putting all the germs into your throat area, then they have to react and inflammation, that's why they're swollen. You don't treat the root cause, you just go and cut them out. What's the difference? No difference. Then you put them with CPAP flatten their faces, right? So they prevent the growth and they have issues as well. So instead, the medical journal is telling you do some maxillary expansion, oral appliances, myofunctional. I try to again escape this word rapid. I don't know why we need to be fast in expanding it, right? Again, if you put expanders in there, RME kind of stuff, again, you block the space of the tongue, you need to retrain the tongue, blah blah blah. Why do it, right? Why don't you just start like the other case, the Invisalign first case, right? You start with the aligners, you train the tongue. When the aligners are done with the teeth, your tongue is also in the right place already. So you do myofunctional. So this also highlights here, that despite the differences in exercises, myofunctional therapy decreases AHI 43% in children, right? So this other paper highlighted that at least 62% in children. So I would just say average 51% improvement, right? If you do myofunctional therapy, and that is the case in. Anyway, like I say, I'm just happy my public hospitals are endorsing this also. So yes, you can do that. Okay, and this gentleman, right? Standard, right? If you have your apnea, you go on CPAP, gold standard. But of course now this gold standard is being questioned. Few things. One is there's a big recall by the Philips respironic system, cancerous gases coming up, right? And also the American Medical Quality Control kind of agency is also asking the question. They are not helping the patient to avoid cardiovascular disease, among other things, as claimed. So you use CPAP doesn't mean you are totally out of the woods. So it's not therapeutic enough also, because you're just leaving to vacuum machine on reverse gear to help you to breathe.
Because American. Everything has to be a fast solution.
Yes. So we know this is not the way forward. Things has to change. So, and how I approach this is that, let's do orthodontics, lifestyle change, malfunctional lingual phenoptony. So this is also published in the Sleep Medicine Journal. Expansion of maxilla in adult with OSA. Is it myth or reality? Alright. So nonetheless, around 10 studies, new or not so new, agree that you can expand without surgery. So for this gentleman, you went for it. So in standing lateral, 107 kg, HI is 68, meaning he stops breathing 68 times per hour. Meaning every minute he has to stop and it's not enough. Okay? So we went ahead and do orthodontics for him. So for 36 years old, we still managed to get this going. Again, lip tie, tongue tie, all the malfunction. Just look at the quality of the palatal shelf. You see it's different. Yeah, I didn't do anything to touch that. I only put the aligner on the teeth. But if you can see, it can grow bone or distort bone or consolidate bone. I don't know. Okay, so this is how it started, and you can see the lateral incisor moving out and the buccal segment moving out. You can see verticalization, right? And then eventually we finish about this position. He lost 40 kg along the way, right? Become a runner, trail runner. Where is that photo? Just a moment. Oh, I'm sorry. I jumped to another to show that.
How much was the pre and post measurement? The spacing in the maxillary, buccal to buccal, or middle to middle. Would you have any records?
So yeah, we talked about that during the recent meetup. So I was just saying it's going to be fantastic because IJOM is going to help out with some of this ability to help us measure and take our data to do that. So yeah. So was lucky that time we were able to take his X-ray. Because he's the distributor for Serona in Malaysia. Yeah, and I literally had him on stage when I presented in the Malaysia Dental Association meeting. So it's the first time to have a patient giving a live testimonial. Because he's exhibiting out there, I said, hey, brother, come in. He gave a talk. And he took his X-ray, we sent it to them to analyze, and he gave us this data. So again, like I say, he's definitely a new boyfriend to his wife, and he's definitely much more fitter, running around more, and very healthy, I would say. Yeah. So that is the component, but yeah, sorry I jumped to it. But I think it's a key point here. I will just probably end off with this segment on bruxism. Okay. So I think Dr. Santosh has we talked about it. It's like, what if they still have good function and they're grinding, right? So we ask this question: is bruxism a parafunction or a protective function? All right. Yeah. So literally, in the International Classification of Sleep Disorder, 306.8, it says that it's a movement disorder characterized by grinding and sleeping. So it's a movement disorder. What movement? We will qualify that later. Little known about natural history of sleep bruxism. It can be related to disorder of stress, right? But also in the second line, it says disorder may be chronic without any association with stress. So can you decide? Yeah. So prevalence, 90% of population grind, 5% of patient present clinical appear to be more affected than adult. Children grind more than adults, so they're more stressed than us. So when you look at the usual thing that you can Google and maybe now ChatGPT, right? They talk about sleep bruxism and awake bruxism, and this is the kind of comparison that we have, right? And the muscles involved, and this is the cause of bruxism is largely unknown. Then they go blah 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 blah. So I decided to configure this into this. Oh, sorry. Let's move it back. Yeah. So this whole blurb is now here. Okay. So this dichotomy is the discussion that we always have. You have awake and sleep. You have stress. You have stress. That's why you do this. And then along the way, they also notice you have high heart rate. You have respiratory changes. You have leg movement. You have gastric reflux. You have decreased swallowing. Then now we have to decipher what are those peripheral things. Why are they happening?
Is that restless leg syndrome?
That's true, yes. So instead of doing this, I break it down this way. Alright, then it becomes apparent. It is just sympathetic response that you are having. Correct? So they're all sympathetic response. Why are you in sympathetic response? No oxygen. So yes, you can't breathe. Right? So thanks to Jules Levine, and so Jules Levine was one of the instructors at Tufts. He of course hold the position at the Faculty of Dentistry, University of Montreal. Wrote that book. If you want to buy this book now, it's $12,000. Someone tried to sell it at 12,000. No, someone tried to sell 12,000. But of course, it's
basically saying it's priceless.
But he was invited to our school and talk about sleep bruxism versus sleep disorder breathing. So now you can see again this linking up, no air, tongue behind, block out, right? Okay. So sleep bruxism is now involuntary episodic repetition of jaw movement characterized by occasional tooth grinding. So tooth grinding is a subset, as a sideshow. Action is jaw movement. Catch your breath, catch your breath, catch your breath. So with this kind of problem, some patient gets Botox. The dentist or the doctor is trying to kill her, so that her jaw cannot move anymore. Can you imagine that? Without knowing the basis or why they do this in the first place. So now it's known as rhythmic mascatory muscle activity, RMMA. Rhythmic mascatory muscle activity, right? So sleep bruxism is in respiratory medicine, chest 2016. Rhythmic mascatory, children grind more than adults, right? And what happens is that first 4 to 8 minutes,